Welcome to today's MASUD Learning Community webinar. Today we'll be hearing from Christy McGlynn on identifying and closing the gap in care for Mainers with opioid use disorder. My name is Bethany with CCSME and I'll be supporting today's webinar. Just a few quick notes before we begin. First, neither the presenters nor the planners have any relevant financial relationships to disclose. This activity has been planned and implemented in accordance with accreditation requirements and policies of the ACCME through a joint providership of the Hanley Center for Health Leadership and Education and CCSME. The Hanley Center is accredited by the MMA Committee on Continuing Medical Education and Accreditation to provide CME for physicians. The Hanley Center has designated this activity for one AMA PRA Category 1 credit. The opinions expressed by the speaker in this webinar are their own and do not represent the position of the state of Maine or CCSME. Recording and live stream transmission of this webinar without consent is not permitted. Now I'd like to give a quick introduction to our speaker today. Christy McGlynn joined the Maine Medical Association Center for Quality Improvement as a project manager with the 1,000 Lives campaign in January 2025. After changing her career from medical assistant to office manager, she continued her education and obtained her MBA in 2018 and followed her passion of working with people in recovery at an outpatient opioid addiction recovery company as a regional director. And with that, I will hand it off to Christy for our presentation. Thank you all for being here today.
Thank you very much for that introduction, Bethany. Thanks for having me. I'm going to start by sharing my presentation. Again, my name's Christy McGlynn. I'm the project manager for the 1,000 Lives campaign. This campaign is managed by the Maine Medical Association with the Center for Quality Improvement. And today, like Bethany said, today we're going to talk about identifying and closing gaps in care for Mainers with opioid use disorder. After this presentation, you'll be able to identify evidence-based intervention for OUD treatment, tailor OUD treatment approaches for diverse healthcare settings, and promote cross-sector collaboration to enhance OUD care and support. What is the 1,000 Lives campaign? Well, we are a provider-led campaign of Maine providers and healthcare organizations in partnership with other efforts and stakeholders to reduce projected OUD-related deaths by 1,000 over 5 years. We do this through systematic implements, primary care practices, surgical specialties, correctional facilities, dental offices, and many other specialties. The specific interventions are tailored to the type of care setting, so they will vary somewhat from one type of care setting to another. Here's a brief update on what the 1,000 Lives campaign has been able to accomplish in our first year. Almost every major healthcare organization and provider association in Maine, including the Maine Hospital Association, has joined the campaign. MMA has also received 2 years of funding from opioid settlement dollars awarded by the Maine Attorney General to support the role of a full-time project manager for the next 2 years, which is my position. Additionally, the campaign recently completed the first ever nationwide survey of opioid use disorder care in all emergency department and hospitals in Maine. Now, before we get into the survey, I would like to talk a little about the supportive organizations for the campaign and discuss the definitions of addiction. We report to Maine legislature every year, and when we submit our progress, we also submit all of the organizations that support the 1,000 Lives campaign. These are currently the organizations participating in the 1,000 Lives campaign that were included in our 2024 annual report to Maine legislature. Here's a link and a QR code if you and/or your company would like to be a part of the campaign. These are the current organizations participating in the 1,000 Lives campaign support as of today for the year of 2025. We will be reporting to legislature at the end of this year, and all organizations for this year will be also included in the report. The formal definition of addiction: a compulsive, chronic, physiological, and psychological need for a habit-forming substance, behavior, or activity having harmful physical or psychological or social effect of typically causing well-defined symptoms upon withdrawal or absence. Here is a list of substance and behaviors that people can be addicted to. When looking at these lists, I would challenge you to identify one or two that you may engage in on a regular basis. Have you ever tried to cut down or quit one of these? Some of these things are very common that people try to quit, but doesn't have high stigma, such as like nicotine and caffeine, because there's a lot of support. You're not looked down upon because you're trying to quit. There is even a lot of people that understand the struggle of quitting with these things such as nicotine and caffeine. When you're trying to cut down or quit one of these substances or behaviors, you have that voice in your head and that strong physical presence stating that it's okay, just one more. One more is not going to hurt. There are so many things that you tell yourself it's okay to start maybe tomorrow or to maybe just take this day off. These are the things that people go through when they say they're trying to stop substances use as well. They are hearing the same voices and the same physical urges to maybe try again tomorrow. Here is the addiction definition according to DSM-5. Addiction, also known as substance use disorder, is defined as a persistent and recurrent pattern of substance use that leads to clinically significant impairment or distress, as manifested by at least two or more of the following criteria within a 12-month period. There's impaired control, taking the substance in larger amounts or for longer than intended, craving or intense urge to use the substance, repeated unsuccessful efforts to reduce or stop use, spending a significant amount of time obtaining use or recovering from substance use. And then there's the social problems, failure to fulfill major role obligations at work, school, or home due to substance use, continued use despite social or interpersonal problems caused or exacerbated by the substance, giving up important social, occupational, or recreational activities because of substance use. And then there's the physical dependence, tolerance requiring increased amount of the substance to achieve desired effect, withdrawal symptoms when substance use is reduced or stopped. And then behavioral changes, use the substance in risky situations, continue to use the substance despite its negative effect or physical or mental health. These are the things they go through that are affecting their daily lives. We need to understand it's not easy to just stop. Now let us look at the overdose deaths in the state of Maine from 2019 to 2024. This will identify that there has been increase of overdose deaths every year up until the year of 2023. We should be proud of what our community has been able to accomplish in the year 2023. We had a 16% decrease in overdose deaths that year. And this campaign started in January of 2024. And at the end of last year, there was 116 lives saved, which is a 19% decrease in overdose deaths from last year. In these last 2 years, we have been able to decrease overdose deaths as a community by a total of 33%. And the average life expectancy for someone is 79 years of age. And unfortunately, average age of overdose deaths is 41 years of age. That is a total of 48 years difference. So with the 116 lives that were saved last year, we have added 4,408 years of lives to the future of Maine. Now, these are amazing numbers, and we really couldn't do it without the people and organizations who really understand that every life really does matter. The 1,000 Lives Campaign Survey. Now, the survey was administered by the Maine Medical Association Center for Quality Improvement, and supported by the Maine Hospital Association. Now, the survey details. We did distribute this survey in October of 2024 to all hospitals and CEOs. All responses were collected by December of 2024. And the content of these surveys was sent to the emergency department OUD care. We sent 5 questions assessing whether EDs are implementing key strategies identified by the campaign to reduce the risk of death from OUD from patients seeking care. Inpatient OUD care, 5 questions evaluating whether hospital inpatient treatment teams are following 5 key strategies to reduce the risk of death from OUD. We ended up getting 100% participation in the survey with every single hospital in the state of Maine. That just speaks volumes on how we all really want to make a difference in our community that we call Maine. Let us review the 5 results of the questions that were sent regarding the hospital ED survey. Does your ED initiate buprenorphine treatment for OUD patients? 26 stated yes, and 6 stated sometimes. Are patients discharged with a 7 to 14-day buprenorphine prescription? 26 stated yes, 5 stated no, 2 did not answer this particular question. Are patients discharged with a follow-up appointment or contact information for a community-based buprenorphine provider? We did get 100% participation. That yes, they all send out contact information to these patients. Have you given your staff in the ED anti-stigma, anti-bias training regarding patients with OUD? 20 stated yes, 12 stated no, and 1 did not answer this particular question. Are patients discharged with naloxone prescriptions or samples on a 24/7, 365 basis? 28 stated yes, and 6 stated no. Now let us review the 5 results of the questions that were sent regarding the hospital inpatient survey. Are you inducing inpatients with OUD who want treatment with buprenorphine in the hospitals? 16 stated yes, 6 stated no, 12 stated sometimes. When patients have been, when patients have been induced on buprenorphine while in the hospital, are they discharged with a 7 to 14-day prescription and an appointment with a provider that prescribes buprenorphine? 25 stated yes, 8 stated no, and 1 did not answer this particular question. When discharged from the hospital with a follow-up appointment with a community-based provider of buprenorphine or names of such provider who are taking patients. 29 stated yes, 4 stated no, and 1 didn't answer this particular question. Have you ever given your inpatient hospital staff anti-stigma, anti-bias training regarding patients with OUD? 12 stated yes, 21 stated no, 1 didn't answer this particular question. When discharging patients with OUD from the hospital, is it with naloxone prescription or samples on a 24/7, 365 basis? 21 stated yes, 9 stated no, 1 stated sometimes, and 3 didn't answer this particular question. Now, these surveys were just a touch base on what is going on in the hospitals today. We are working very closely with the CEOs and staff to make all of these changes. The leading cause of death in US and Maine in overdoses. OD deaths rank about 7th as the most common cause of death in the US, just behind diabetes. In Maine, 409 deaths in 2024 versus 171 for motor vehicle crash. We're about the 6th leading cause of death in Maine. It is the most common cause of death for Mainers under the age of 50, as well as the largest cause of preventable life years lost in Maine. Average age of death from OD is 41 years of age. Patients with opioid use disorder face mortality rates comparable to those of heart attacks, underscoring the urgent need for accessible, evidence-based treatment in primary care setting. For hospitals and emergency departments not offering buprenorphine treatment 24/7, 365. This is as though you were treating some patients with acute heart attack in the ED, but not treating others patients with acute heart attacks in your ED. Same for inpatient, as those you admit some patients with heart attacks and treat, but admit other patients with heart attacks and don't treat them. There's really no indefensible double standard of care for patients with life-threatening conditions of opioid use disorder. The case for doing OUD care for buprenorphine in primary care. Substance use disorder is a routine part of primary care. Integrating OUD treatment into primary care ensures patients receive comprehensive care that addresses both their addiction and other essential health needs. We need primary care access to buprenorphine for OUD to help shift stable patients from specialty addiction clinics, alleviating their burden. With the high demand for OUD treatment in Maine, relying solely on addiction medicine practices is not a sustainable solution. We need follow-up access for OUD patients from hospitals and EDs. Hospital and emergency department induction on buprenorphine, most of the barriers are now gone. And this is something that a lot of people are not aware of. So I'm just going to go through this little list of things that are no longer barriers and where we can help. There is the lack of evidence base that this is life-saving care that is gone. Lack of clinical protocol and workflows that can be shared are gone. Need for an X waiver to prescribe buprenorphine, that's gone. Lack of follow-up rapidly available OUD buprenorphine prescribers, that's gone. Lack of standard of care, that is gone. Lack of help for your hospital or your EDs to implement, that's where we can come in and help with everything. And that's from just induction, stigma training, everything. Our goals for 2025 for the 1,000 Lives campaign is closing the gaps in ED and hospital cares in Maine. Emergency departments we're trying to close the gap in EDs and hospitals in Maine, excuse me. Emergency departments all doing 24/7, 365 induction and follow-up scripts and referrals by January of this year. Hospital inpatient care and doing 24/7, 365 inpatient inductions, follow-up scripts, and referrals by December of 2025. And that is the end of my presentation. And here is Dr. Eric Steele's information at eric.steele@martinspoint.org. If you have any questions for him, he is the campaign chair. And here's my information, Christy McGlynn, the project manager, and that is my email, cmcglynn@mmacqi.org, and my phone number is 207-287-0287.
Thank you so much, Christy. So one of the questions, what is the goal for the by the end of year 2026?
So, as we're closing the gaps in emergency departments and in hospitals, we're currently now starting to talk about bridging the gaps with primary care, as in my presentation. There's a lot of room to be able to move. There's a lot of room to be able to move stable patients or people with substance use disorder into primary care where they can take care of them, which alleviates more rooms and availability in substance use programs. So all of 2026 is really reaching out to every single primary care provider, every single primary care office, and seeing what we can do to help them get off the ground, like stigma training, inductions if needed,